Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. I hope everyone's doing well and settling back into their routines as summer winds down. Can probably all agree summertime's wonderful, but there is definitely something to be said for getting back into our routines that happens come fall time. It's funny, my orthodontic colleagues out there can appreciate this, I'm sure, but when kids go back to school, our practices literally go from 1,000 miles an hour. Everyone's scrambling to rush to get in. They want to, get in last minute. And then all of a sudden in a day, it's like no patients want to come in except maybe our older adult patients. But no one's interested in coming in. And we actually used to, started after a few years in practice, I realized those days were tough days. So we just closed those days and close to patients, and we made them admin days. And we would just do team building activities. We'd do our CPR training, our compliance for like HIPAA and OSHA. And we just kind of made them relaxing, fun days. And it was actually really nice for the team because after the busy pace and the frantic pace of summer in an orthodontic practice, kind of nice for them to look forward to just a couple days where they didn't have to deal with any of the patient side of things. So just a little tip for people if it's something you have been thinking of trying, because those can be pretty tough days in an orthodontic practice when you get started back. So with that, I want to introduce my colleague and very special guest, Dr. Marianna Evans. Many of you likely know Marianna and either personally or you've heard her speak or you know of her work or have read her literature, but she's extremely prominent in both the orthodontic arena and really the dental profession in general. She even carrying over into the medical profession with a lot of her work, which we'll talk about, especially as it pertains to anthropology. Just to give you a bit of background about Dr. Evans, she is a board-certified orthodontist and periodontist. And she's the founder of Infinity Dental Specialists in Southern Pennsylvania, which is an interdisciplinary practice that focuses on orofacial development, periodontal health, and airway health. She's an adjunct professor at the University of Pennsylvania in the sleep surgery department and also conducts research in the Department of Orthodontics at UPenn. Dr. Evans further conducts research on the relationship between oral and systemic health. And she's published several works, including notably the American Academy of Periodontology Best Evidence Consensus Statement on Selected Oral Applications for Cone Beam Computed Tomography. We're going to dive much deeper into her background, her research, her clinical practice, and her significant contributions to the profession during today's episode. So with that, I would like to welcome Dr. Marianna Evans to the Doc Podcast. Welcome to the show, Marianna.
Thank you so much for having me, and happy Friday.
Yes, happy Friday. I'm really looking forward to having you on. We've spoken separately, and I've known of your work for a while as I've learned more in this arena and come up through this sort of educational journey that I'm on. But first off, that stood out when I looked where you practiced when we first were talking. And so I was in Southern Pennsylvania and I went to Villanova, which is literally a few miles from where you practice. And my senior year, I lived on Brook Street, which is literally like 10, 15 minutes down the road from your office. So I was like, oh my gosh, what are the odds that I literally lived my senior year right by where you ended up starting a practice? It's crazy what a small world it is. But tell me a little bit about your practice. Just kind of what do you do? What's your average day look like? What are you doing? Do you have colleagues you work with, associate doctors, and what the life like sort of in the day of you and your practice?
Sure. I, as you mentioned, I practice right outside in the suburbs of Philadelphia.
Mm-hmm.
My practice is interdisciplinary practice. It's a peri-ortho practice.
Mm-hmm.
So I am an orthodontist and a periodontist. I have another colleague of mine who is a periodonist working with us, and also another orthodontist. So
Okay.
two orthodontists and a periodontist. We have two locations outside of Philadelphia, about 20 minutes apart, covering different geographic areas. Both of our locations are in the medical buildings. So we have ENTs, we have sleep centers, we have sleep physicians and pulmonologists in both of our location. So it's very nice to integrate all these medical specialties together with orthodontics.
Mm-hmm.
And I see patients 4 days a week, Mondays to Thursday,
Mm-hmm.
and occasionally some Fridays as well.
Mm-hmm.
And Fridays I usually do either lecturing or schedule meetings or travel. And it's nice to have like a 4-day working week.
Yeah.
I don't know if I could go back to 5-day. So my practice, when it comes to orthodontic side of it, is very focused on airway, I would say. Luckily, today, 99% of the patients come to us not to address the bites, but actually to with hope that we can help them sleep and breathe better. That actually counts for adult patients and also for pediatric patients. Being part of the pan sleep surgery department allows me to see a lot of many adult patients with sleep apnea, upper airway resistance,
Mm-hmm.
and a very large percentage of my practice is children under age 6.
Okay.
Where we are doing some very early skeletal intervention, orthopedics to open up maxilla and also help mandible, guide mandible to grow a little bit better forward, controlling the vertical dimension. Another special thing about our practice is that we see families. We have a very nice population of patients where I'm able to see parents with orthodontic and periodontal needs, and also we see their children. So it's a very nice mix of adults and children where we can see the complications that are happening in adults. Don't treat face and you don't treat the bites in a young age. And also it's nice to see young children where you can actually make a huge difference for them, treating them younger. I started my practice in 2011 from zero. And I think this was the best decision I made when I was graduating from my residency in 2010. It was a big decision whether I want to buy or join existing practice or start something from scratch. And I think it was a very difficult journey. This is now 13 years since I opened the office, but one of the best decisions I made in my professional life.
That's interesting. I just did so much you said there that I love, and we're going to dive deeper into because you just have so many things you're doing that are so advanced and so far ahead of where a lot of our colleagues are. And I want to talk more about that. One interesting thing, just as a little aside, what you said about starting your own practice and a big decision. I literally, my lecture yesterday to the residents at Nova was a 3-scenario three options, 3 different scenarios that we kind of role played of what they would do. And it was a real story of a doc that I coach and help and the coaching side of what I do on my platform. And so I just gave them the scenarios, and they were different scenarios of, buying an existing, trying to start your own, different scenarios of buying a practice that's not doing as well versus one that is doing a little better, but old versus just a de novo startup. And it's funny you say that because we all face that, but people probably don't realize we get zero training in how to make that decision.
Zero training.
And so we come out, and it was really a fun lecture. And because the residents, I try to tell them, you've got to figure out, who do you want to be in 20 years? Like that, because we get so caught up in the X's and O's of, well, they want this much for this practice, or this is going to cost me this much in a loan, or this practice has, is in this location. And I'm not saying those things aren't important, but in and of themselves, if you don't know what you want to be doing 5, 10, 20 years down the road, no one teaches us in our schooling. It's almost the opposite. We just learn how to get to the next hurdle, and succeed. I find it one of the things I try to do the most with people I coach and teach is how you have to know what you want to be doing in the future. So would you agree that did part of your decision come into play, that what we wanted Marianna to look like in 10, 20 years from the time you started? Was that something you knew back then?
Well, I always knew that I wanted to have my own practice.
Okay.
But it's the journey that I wasn't sure about. Like I didn't know how
Fair.
do you get there. Do you
Yeah.
uh, buy a practice from somebody who is retiring?
Mm,
Do you buy the practice and into a big interdisciplinary practice or a group practice?
mm,
So it's a big decision. Or do you start from zero and take a huge loan? And now you
yep.
have, I was at Pants for 6 years, so I had huge loan,
Yeah.
on my part.
Right. Because you did both specialties. Right. Right.
Exactly. So my husband is a financial planner, so he kind of helped me make that decision. And
Mm,
exactly what you were saying, he was saying to me, like, if you can't make a decision, you have to ask yourself, where do you want to be 5 years from now?
mm, mm,
And then we looked at the spreadsheet, we looked at the numbers, and it basically told me that 5 years from now, if I don't start from zero, I'll be exactly where I'm right now, graduating from my residency. So I
mm.
still will be starting the same,
Yep.
except 5 years later.
Yep. Yep.
And that was like an eye-opening experience for me. So I said, I have to do it. I have to start from zero because
Yeah.
that's what I and it happened.
Yeah. And you've obviously done very well with it. Although I know from starting my own from zero that it's not easy. And now that you're 13 years in, I'm sure a lot of people look at you and it looks easy, and you've got this well-oiled machine that patients are impressed by and seeking your care. But it is a grind in the beginning. And I
It
will.
was difficult. It absolutely was difficult,
Yeah.
but I could have done now, looking back, a few things differently,
Mm,
but I do not regret a moment from the experience that I went through and learned from
mm.
going through this experience. So I'm very happy.
Yeah, that's how I felt. No matter how hard it got in my practice, I never wished I was working for someone else ever. Not a day, not a second of a day. Did I ever wish that I was not the one running the practice? So, but again, it was my vision. I knew that. I knew I didn't want to be showing up and being told how to practice. I just knew that about myself, and that's what I really try to encourage people I teach and coach and the residents to think about: is who are you? We don't get a lot of time to think about who we are or really what we want. We just keep doing. I want to be an
Exactly.
orthodontist. I'm like, well, that's great, but that doesn't define who you want to live the rest of your life as. Yes, that's your occupation, but who are you? Are you the type of person who just wants to go to work a couple days a week? Are you the type of person who wants to see patients 4 days and then live with running the practice the other days, as I did? That was my schedule, and yours sounds like from what you said as well. So no, I appreciate you sharing that openly, because I find that I have a lot of docs of all ages that follow my content and listen to the show, but I do have a good following of residents and younger docs, and they constantly am hearing that same question. So actually, coming up on a little preview on some episodes coming up in the next months, I'm going to try to get some residents and some younger docs on the show to just talk a little bit about what they're going through in their journey, because it's just something we just don't get it. We just don't get any education in this in our training.
But it's not for everyone. I think for some doctors to be an associate is the best thing.
I agree.
There are definitely moments in my life where I feel like I wish I didn't have a headache of running a practice,
Mm,
managing people, and I would just walk in, see the patient, and go back and
mhm.
leave everything
Yep.
in the office. So I think there is definitely benefits of both, and you have to make a determination what exactly you want and go for it.
Yeah. No, that's great. Great advice. Why did you end up doing perio and ortho? How did that come to be?
So that's an interesting question because I am originally from Ukraine,
Okay.
and I did my dental education in Eastern Europe, in Ukraine, and a very small country of Moldova,
Okay.
which is between Ukraine and Romania. So we don't have a specialty in periodontics. Maybe now it has changed, but back then 26 years ago, we didn't have specialty of periodontics. And if you want to do periodontics, and that's what I wanted to do,
Mhm.
you have to go through oral surgery training
Okay.
to be able to do endosurgery and periosurgery. So I did that, and I really wanted to be a periodontist.
Okay.
So when I came to the United States, I already came after practicing for 3 years, very basic perio in Ukraine, in a private practice, and I started advanced standing program at the University of Pennsylvania. And my goal was, after I get my license in the United States, I will go for the perio training, because I wanted to specialize in periodontics. And in the first week of my advanced standing program, I had a lecture by Dr. Van Arsdal, who at that time was a chair of orthodontic department and program director for perio ortho program. And he gave this amazing lecture on molar writing and perio ortho interrelationships. And I never was interested in orthodontics. Orthodontics was completely different world from me. And it kind of brought it together, the correlation in adult patients between malocclusion and periodontal health. And I kind of realized after this lecture that that malocclusion component was something that I am actually very interested in. And so I knew after that lecture that I want to do this combined training. And that was another best decision. The first best decision before opening my practice that I made is going for this program. So
wow, very interesting. It's funny how when I talk to different people and I learn about their stories, which I love hearing the journey, because people see us in our capacity currently. It's just kind of human nature. They see you, Dr. Evans. You've got this amazing reputation and very prominent figure internationally, and they don't realize there was a day you had to make a choice like this. Like, you had this moment, and you're in Dr. Van Arsdale's lecture thinking. But I think the key I find in people who really achieve high level success is, and I don't even mean that in terms of like financial or infamy or fame. I mean it more just in high level of success, as in they're accomplished and highly achieving things within their respective professions, which you clearly are and have. There's always a part at which you kind of have a crossroads, at which you have a big decision to make, and many of those crossroads potentially. I mean, you had one we just talked about with starting a practice. You had another one with going in now double degreeing. Here you focused on perio. You were all in on the perio side of things, but you kept an open mind, and you always were open to trying to be that much better and be able to follow what you wanted to achieve in the best way you knew how to do so. And I find that's a really common thread with a lot of people who, again, achieve a high level of success. They don't just go through the motions and say, I'm going to do this and I'm going to do this. They actually are always questioning, and they're always pushing the envelope, and they're always pushing their own comfort zone. And I think, and we'll talk in a little bit about, some of the people who resist a lot of the things that you and I do and teach and promote. And I think that's one thing that I've seen in common is some people just aren't willing to push that comfort zone. So, I can't imagine what you were going through as a resident, all in on perio. I'd be like, yeah, I think I want to do ortho too. I mean, for people out there listening who aren't in the profession, that's not like a small decision. And that's not like, oh, maybe I just take another course. What did it involve?
A weekend course, right?
You're not taking a weekend course at that point. So did you have to you went 3 years perio, 3 years ortho? Is that what happened?
Well, PAN is the only school that offers a combined program where you do just the first year of perio in the first year of a 4-year program. Then the second year, you kind of double. You do the first year of ortho, and you continue all the classes of the second year perio and the patients in the perio department. So you basically run between two departments, and you do double as you compare like the perio residency separately from the ortho. You have to still fulfill the requirements for those programs for the second year. And then the third year, you do the second year of ortho, and you do your last year of perio with all the didactic requirements and clinical requirements. And the fourth year, you kind of combine and you make a fusion out of it, doing what you like to do more. Like, do you like to do more perio? Do you like to do more ortho? Like finishing in the same time, finishing all the requirements, clinical requirements, and doing a lot of presentations. and starting to focus on what you enjoy the most. So it's kind of a nice 4-year program.
Yeah. Wow. That's an intense 4 years. What's that?
And finishing the research.
So you had to do research in both.
Well, I didn't have to do research in perio, but I did have to do, it was mandatory to do research in ortho.
Okay. And then with that, how did you, pardon the pun, evolve into anthropological research? How did that happen? I mean, from perio, ortho, malocclusion, how did you did you realize that? Was that sort of the thing, like what you said with being in one lecture with Dr. Van Arsdale and it was a aha moment, or was that something that took a period of time for you to start to understand that? Hey, everybody. I want to take a moment to tell you about today's sponsor, Reliance Orthodontic Products. We all know that broken brackets and appliances are some of the biggest stressors in an orthodontic practice. And what about that feeling when you debond a beautifully treated case only to find white spot lesions all over the teeth? That's why I rely on the products from Reliance. Whether it's Assure Plus, their absolutely amazing all-surface bonding resin, ProSeal to virtually eliminate decals from your practice, Go-To bracket adhesive to improve bonding strength and make cleanup a breeze, BandLock to cement Herbst appliances and build up bite ramps, or LCR Paste for clear aligner attachments and incisor bite turbos. Their products are second to none, and I literally couldn't imagine practicing without them. Plus, their products are very fairly priced and they stand behind what they sell. The amazing people at Reliance will even work with you and your team to establish simple and effective bonding protocols. So if you want to take control of your bonding, visit RelianceOrthodontics.com to learn more about their amazing products. That's RelianceOrthodontics.com. Trust me, you won't regret it. And now back to my interview with Dr. Marianna Evans.
So that moment about anthropologic side of it happened to me. The aha moment happened after a lecture in the ortho department by one of our faculty on the etiology of malocclusion.
Okay.
And the maxillary deficiency. It was a lecture by Dr. John Hayes, and he published a little bit on transverse discrepancy and how he measured it, his own technique. So he gave this amazing lecture about ancient skulls that had these perfect bites that didn't need orthodontic treatment. And it really kind of settled in and when I was already teaching after I graduated and practicing, it really started to grow on me. And very luckily at Penn, we had this amazing department of anthropology. And
talk a little bit about that. So people who don't know about that.
We have at Penn one of the largest human collections of pre-industrial skulls, and it's a very diverse. It's called a Morton collection. It's a very controversial collection. The way it was and the reasons behind why it was collected, you can look online. And it's a diverse collection of not ancient skulls, but pre-industrial skulls that are, some of them are 500-600 years old. And very few other museums in the world have this diverse collection like Penn has. So I always was interested in expansion. Like Dr. Van Arsdale was all about expansion, non-extraction therapy in our program. And we always were trying to learn how to diagnose who do you expand, which patient expansion, and how much do you expand.
Love that.
So to be honest, until today, we don't have a consensus on this and we don't have a good answer.
You're reading my mind. Yeah, I was thinking exactly that as you were saying that.
We have a lot of papers on expansion,
right?
And what we get with expansion, but we have very little evidence on what is the goal, right?
Yeah.
And some more evidence comes out after we have CBCT imaging, but it's still not enough. And the reason why it's not enough is because how do we get the normals? Normal patients that don't need expansion don't really come to the orthodontic practice. So where do you get these patients that don't need expansion to identify how do we treat the ones that need expansion? So when you look at all the studies that we have on transverse problem, they are not based on what it should be. They are based on what the patient's skeletal structures look like today, and it's post-industrial skulls. These are the skulls and anatomic jaws, the jaws that have impacted wisdom teeth, that have some degree, some level of crowding, right? And it's not good enough, at least for me. So my question was, I wanted to know what is the transverse relationship between maxilla and mandible at the level of the teeth, at the level of the bone, in skulls that have 32 teeth in functional occlusion. So those 32 teeth, the way the nature designed us, are critical. Every single normative study in orthodontics today is done within the last 70, 100 years, and based on post-industrial deficient facial skulls that have no more room for the wisdom teeth in the jaws.
Can you just take a moment to explain why that might be for people listening who hear that and say, I don't understand? Can you just go a little bit more into some of the theories as to why that is?
I think when we want to identify what is normal for the facial jaw development, we should be looking at the jaws that have 32 teeth in the mouth. At least if we don't have them in the mouth, we have room for 32 teeth, because the nature didn't design us to have 28 teeth. The nature didn't design us to have extracted premolars. We want
24 teeth. If you have premolars out and wisdom teeth out, you're left with 24.
We don't know, we don't have the data, but because nobody in the studies on normal facial development, whether you look at the sagittal, vertical, transverse, included skulls in the orthodontic profession was 32. The criteria was never 32 teeth in functional occlusion. The requirement was never to have room for 32 teeth. We were happy to have 28 teeth that don't need to be removed orthodontically. That was the standard. It should be the standard.
What is some of the theory behind how we got here in just a millisecond of evolution, which, if Homo sapiens are 300,000 years and evolution, some people say 3 million years, 6 million years, a long time, right? Clearly 300 years is like a fraction of a millisecond. How did we go from pre-industrial having, broader jaws? You have the data there at Penn in the museum and showing these broad arches, full complement of dentition, to now a very short period of time, on a magnitude of a couple generations in some cases, a few generations at most, these narrower arches with all this crowding. How has that happened in what you've studied in your knowledge of it?
So, I studied the anatomy of the skulls that have room for 32 teeth. I looked at the skulls in all planes of space, vertical, sagittal, transverse, all the way from the orbital areas to the bottom of the lower jaw. And I am now comparing this data to patients from my practice that need expansion. There's a very obvious maxillary deficiency, and there is a very big difference. When it comes to why it happened and why it happened so fast, and again, Morton skulls are not 1,000 to 2,000 year old skulls. They are like 500, 600, 300 years ago. So some of these skulls are very recent, right? And they come from all over the world. Well, there is literature on that. And the anthropologic evidence shows us that it takes only one generation to see a skeletal change in the face and the mouth from whatever factors. It could be a genetic factor that takes several generations to enter the gene pool. And I think the malocclusion with deficient mandible and deficient maxilla is already in the gene pool, because I see a lot of patients where the parents have children with very similar maxillary mandibular deficiency. However, there is a very strong environmental influence. And the evidence shows that from 1940s to 1980s, we have an incredible rise in malocclusion, in crowding in the primary dentation, for example. I'm talking about permanent dentation. We know that if we have crowding in the primary, it's going to be crowding in the permanent dentation. I'm talking about comparing children from 1940s to 1980s. In the primary dentition, the crowding has increased dramatically. It's pandemic problem now. So the jaw structures are not growing. And the reason why, because there are major environmental changes in our diet, in the consistency of the food that we eat. If you look at the jaw development, the biggest velocity of jaw development happens within the first 24 months of life. If you failed to grow to the size of the jaw it should be at the age of 2, you can never catch up and grow those jaw structures after age 2. So what happens before age 2 is the bottle feeding versus breastfeeding, and also introduction of solid foods. So the way the children are raised today is completely different from the way they were raised even 100 years from now. Even it's different between like Eastern Europe and United States, for example. What about putting a 2-month-old in a daycare and introducing all the other viruses and bacteria to that infant and getting that infant sick from 2 months old? That is not formula already from birth. What about all the pollution in the air? What about all the factories that create pollution, air conditioners, carpet, all the allergens that we have in our food and the environment? So if you introduce astronaut diet to a child that should be starting solids, and if you introduce all the allergens, sugar, and everything possible that causes the nasal congestion, and that poor 1-year-old can breathe through the nose, that's enough. And if it happens 6 times a year and it takes them 6 weeks to recover each time, that's how long they have to suffer and not breathe through the nose. That's enough for the face to stop growing correct.
That's such a great point, because it's those episodic incidents where it's really severely blocked. Then you add on the chronic nature of, say, just turbinate hypertrophy or certain obstructions of the nasal passageways. There are studies that show that in 40% of children are suffering from some sort of turbinate hypertrophy. So you have this chronic nature. Then you make a great point with all the infections. These kids are getting young. You start to have obstruction of the nasal breathing, and that's something which I want to dive into more, because somehow this is still controversial, and I want to get your thoughts on that. But we can quote the data. I mean, you look at the studies from, even Harvard's, rhesus monkey data with his purebred rhesus monkeys in the 70s, and plugging their noses with silicone and looking at them in 6 months and then 2 years, and the tremendous changes in growth and development of the face. I know, obviously, Melvin Moss in the 60s in the functional matrix, and Enloe, and talking about the craniofacial complex and growth disturbances in one area impacting another. So a lot of people still dispute. They say, oh, the functional matrix, and Lyle Johnson and people put papers out saying it's disputed. But fine, if you want to argue over the semantics of the functional matrix, that's beyond my pay grade. That being said, the data are so conclusive that when you obstruct nasal breathing, right, you change the way our face grows. And it's interesting because a lot of the people who throw some shade on that and say, no, I mean, I've had people online say to me in forums, there's orthodontists, colleagues, there's a mom and a dad, and that is the etiology of the malocclusion, nothing else. But those same people will admit in what we call adenoid facies, right? And they are like, yeah, but well, occasionally they might have enlarged adenoids and that could do something. And I always say, you can't have it both ways. Like, either it's all genetic, and you're going to stand that, because when you say it's just a mom and a dad, you're saying it's all genetics. There's no environmental influence. That's what this person was saying, that etiology is completely 100% genetic. The preponderance of data.
That's what I call lack of education. Okay?
Right?
That lack of education starts in your residency.
Yeah.
When orthodontic residency is one of the most difficult residencies to get accepted to.
Yes.
So if you get accepted to it, the ego just goes from the floor all the way to the ceiling and beyond. And you think that's it.
Yep.
Whatever they feed me with the information, I don't need to question anything.
Yeah.
That's 90% of orthodontic graduates. They think that what they are fed and taught in residency, that's it. And that's like 1% of what they need to know.
Yes.
No, I'm serious about it. And I'm very disappointed. But what you are talking about, all these controversies on forums where one contradicts themselves with like, oh, adenoidal face, or here it's a genetic, like this is lack of education.
Right.
Go stop looking at the stocks on your computer, go read the literature. How many people are actually reading the literature after they graduate from their residency?
They're not.
So go and educate yourself. There is literature on this. And you don't have to have your colleague on Facebook that doesn't read the literature teach you what you need to know.
Right.
So I think this is what is happening, that orthodontists are not, the literature that you read in residency, it's so outdated and it's so like selected. And
selective. Yes.
Very selective. And it was developed too many years ago. We have evolved from what we are teaching these residents. Like the way I practice is very far from what I learned in residency. And I think my residency program was probably one of the best in the world. But I read a lot of literature after. I didn't stop. There is one thing that I would like to give advice to the new graduates, if you have them on your forum, is what you need to realize, what you learn in your residency, it's 1% of who you should really be professionally. The financial, the business side is another side of it where you get nothing in your residency, right?
Nothing.
Zero.
Yeah.
So you have to kind of learn this after you graduate to educate yourself. But when it comes to clinical practice, everything you will learn in your residency, you have to question. If you don't question what you are given, then you are lost. You are going to be behind.
Yeah.
And if you are going to question and really continue your curiosity, you have to continue reading and educate yourself after you graduate. The moment you stop reading, the moment you start dying as an orthodontist.
Yeah. Oh, that's so well said. And I'm glad you took the time to say that, because I feel so similarly. And I talk to the residents all the time about this when I'm teaching them, and the need to seek out more. Don't just settle for what this faculty member or this particular person you follow in the literature says. Look for other ways to do things, right? And I've when I lecture and on my website, I have Steve Jobs quote, "Don't be trapped by the dogma of other people's thinking, which is living with the results." And I find in I love that, because I feel like in orthodontics, we get so dogmatic, and we are okay with living with poor results a lot of the times, because we feel like that's the way we did what we were supposed to do. And I tell people, you've got to break free from that. You've got to always try to get better. And to your point, I went to UConn, right? Charlie Burstone, Ravi Nanda, purebred biomechanics. I never would be the orthodontist that I'm able to be if I didn't have that training that I got there, right? I mean, I learned how to move teeth probably as well as anybody, because those people being my faculty and directors. That being said, we had no education in airway. We had no education in, I went back, I found some articles that I had some of Corcini's studies and Harvard studies, but we never really focused on them. Certainly didn't retain a lot of it, but as you had alluded to, I went back, I reread, I tried to find old articles and new articles and compare data. And I pushed my envelope of thinking. And when I got into practice, started my own, didn't have to listen to anybody else's way, right? I didn't have anybody else's way. I didn't have any patience. I had to figure this out. And I started doing exactly instinctively what you described. And that was, I started looking at these patients' arches and their development or lack thereof craniofacially, and saying, and this is before I still had no idea about airway. We're going back 20 years ago. I wasn't thinking breathing. I was just looking and saying, wow, these kids are coming in at like 6, 7 years old to my practice for the first time. I didn't see many of these in residency, hardly any. So I really didn't know what to do with them because we don't, most people don't realize we don't even get trained in 6, 7, 8-year-olds in most residencies. It's a whole nother discussion for another day, but the system doesn't get us those patients young based on the way it's set up. So I'm seeing, but in private practice, that's when, you're going to get patients that age, majority of your patients. So looking, and I'm like, yeah, they're crowded. But I had remembered the McNamara study from '83 with O'Connor and Howe, where they measured teeth of, I didn't remember the number, but I now know the number. It was 104 patients. They took 54 with severe crowding, 50 with no crowding, and they measured the teeth. And guess what they found? The tooth size wasn't variable. The jaw size was. And that Mills has a study on this. And so there's all this literature out there that talks about, wait a minute, this isn't a tooth size problem. Again, we're talking majority of the cases. I'm not talking isolated cases, majority of the cases. So I'm looking and I'm going, teeth aren't big. Like, this kid doesn't have big teeth. They might look big because they got this little teeny face, but if you measure the teeth, they are not large. They are not macrodontic. So why are they so darn crowded? And then the only other way it can be is the jaws are small, right? I mean, if you have crowding, it's big teeth, small jaws, or a combination of thereof. Like that's it. It doesn't get any more it's really simple. It doesn't get more complicated than that. And I did what you said. I literally, no joke, Marianna, would go. I was teaching at UConn part-time adjunct from the time that I left my residency and started practice. I would go back once or twice a month. And I would go early because this was before databases were all online like they are now. And I would go back early and I would sit in the library. And sometimes I'd stay late after clinic and go to the library and I would pull articles and I would just start reading about early expansion and about mandibular expansion, which, my goodness, if you mentioned that in probably 75% of residents, there's probably people listening to us right now that just fell over when I said that. So, to clarify, we're not talking about expanding the mandible. We're talking about expanding the mandibular arch and getting the teeth over bone. We understand that the midline symphysis fuses around birth. Like, I got that disclaimer out there. But when you start looking, and again, their data, and then not long after that, McNamara had another study with Frankie Bichetti that they looked at this was in like 2006. They expanded the mandibular arch and then the maxilla. And they looked at, and they had 27 patients who were in the maxillary expansion only group, 23 in the maxillary and mandibular expansion, and 16 in the no treatment. And they measured them over time, 4 different time points over 20 years, and found that even at 20 years out, the greatest stability was in that middle subset who had mandibular arch expansion and maxillary expansion at a young age. And when I think their patients were about nine-ish.
Was old
9,
age.
Yeah, 9. Yeah.
Imagine when you do something starting at age 4, age 5, age 3.
Yeah, let's talk about that, because when we talk about this, I find there's 2 different things that I often get challenged on when I talk about this. One is what we were just talking about, and that is malocclusion is etiologically determined by genetics only. And you have no real benefit to start treating these kids at the traditional early age, which we were just saying is kind of that like 7 to 9 range. And there's no net benefit, and you don't expand the mandibular arch. You just deal with the maxilla, and phase 1 makes no difference. And I could quote literature all day on some of the poor studies that say that, but that's one area people say that what I'm saying is incorrect. The second area is what you just said. And that takes it a whole nother step. And that is, let's not even go in and talk about this discussion at doing this at 6, 7, or let's just say 7 to 9. Let's do this at 3, 4, 5. And that takes people who may even agree with the first part of what I was saying, right? They're like, they could handle that. And then they're like, mind blown, like, no way. So let's go into that a little bit. Talk about that side of it, going in even younger.
Mm-hmm. So I think that if you're going to make a difference, you have to start in the primary dentition as early as you can. And today, with 3D printed technology, with intraoral scans, you take it and run with this.
Yep.
Because if you are not going to do it, the pediatric dentist around the corner is going to take it from you and run with this.
Can you say that part? Can you say that part again, please? Because I say that all the time. And please say that part again, so people, if you're driving, if you're on the treadmill, like listen to what Marianna is saying here.
So I'm saying that a few years ago, you didn't have the tools to treat younger.
Mhm.
Today, we have the tools to expand these skeletal surfaces to much younger children that can tolerate this treatment in a younger age.
And then the other part of that, Marianna, sorry, is if we don't do it, what was the part you said
If you
about?
don't do it, then somebody else that is smarter than you is going to do it. And the reason why they're going to do it, because there is a huge need for the health reasons, not for cosmetics, but for the health reasons to do it in a younger age.
Yes.
And now with all the information being fed to the public, there's going to be a demand, but the parents are going to demand it. And if you don't offer these services, somebody is going to offer them.
Yes. And for the orthodontists out there, oftentimes that's going to be the general dentist and the pediatric dentist, just to call it what it is. They are going to be taking your patients from you before they ever walk in your door. And we are going to suffocate our profession by refusing to wake up and grow our wake up and evolve in terms of our mindset and what's possible. And again, that's me saying that.
If people are really worried about the steak, that piece of steak, okay? So imagine a liner business, okay? A liner business is already in the hands of general dentists.
Yes.
And in a big percentage in the hands of the pediatric dentists. But the general dentists, the restorative dentists, they already are doing aligner therapy. So imagine there is definitely now clear demand for doing things earlier with the risk of sleep apnea, with the periodontal risk. That's another big one. Something in the primary dentition. So let's say, and we now have the tools to actually do it. Before we didn't have the tools, you don't want to put a separator in a 3-year-old.
Right.
So then you don't have to take a mold on an alginate mold on a 3-year-old. You don't have to put a separator. You can do a very minimal invasive treatment in young children, right?
Yep.
So that, and they can do great, and they do great because we have these patients in our practice. I know that they can tolerate it, and we see the results. So the point is that the Invisalign business, aligner business, is already in the hands outside of orthodontic profession. So now, if orthodontists are going to refuse to treat children in the primary dentition, and the demand for this is going to increase, so this part of population is going to stay with the pediatric dentist. Is going to stay with the dentist, general dentist that is going to treat children. Okay. So once you treat children in a young age, and I'm not talking about using ALF, I'm not talking about using removable expanders that don't work, that tip the teeth. I'm talking about doing orthopedics in young children to change the jaw structure, to help permanent teeth erupt healthier. Once these permanent teeth erupt healthier, then you can avoid maybe braces in these patients, and you can avoid extraction, and you can maybe close those open bites that everyone is afraid to treat and refuse them to the orthodontist. So once you get that primary dentition treatment and set it up for the healthy eruption of the permanent teeth, and then make the case very simple to treat, where you just do very minor alignment. Guess what happens to the orthodontic profession? It's going to die. Okay? Because you don't need anymore a very advanced specialist to move teeth. You don't need them. Okay? So the reason we have orthodontic profession today, because we missed the diagnosis for 100 years of this profession. We were moving teeth from the front to the back. We separated the transverse problem from crowding, from the sagittal. We did nothing about controlling the vertical dimension. overgrowing, over erupting teeth from a young age. We did nothing about that. We actually did worse. We made it worse by extruding the teeth with Hyrex expanders. Now, 100 years, so whenever you started to use Hyrex expanders, we did damage. We moved the teeth 400 years outside the bone with extractions and without extractions. We have patients that are going now through 3, 4, 5 rounds of orthodontic treatments where they cannot get the teeth touched, where they have the teeth and the roots outside the bone, where they have no roots left, and the teeth have to be extracted, and the jaws have to be reconstructed with the jaw surgery, with huge implant reconstructions. We fail. We have 100 years of failed profession.
Yes.
So it's going to die, or we have to open our eyes, stop for a minute, reorganize the research that needs to be done, and take it to the next level. So we have a choice. We are standing on the edge of a cliff. Either we have to fall down, or we take something and we fly up. So that's where we are.
Yeah, I love that.
Do you agree with me?
Oh, I mean, I couldn't agree with you more. And you said it so beautifully and directly, which I love, because I'm not afraid to talk about this stuff. And I love that you're not either.
Right?
I love it. Yeah. Yeah. I love your courage and your passion. And I feel so the same way. I have said so many times, we are literally digging our own graves in this profession. And I say it to any of my residents, if they were here right now, they could say, yep, Mike says that, like, because I'm always telling them, if we don't wake up, we are going to lose our profession. And because you said, what I love that you said that I haven't been as articulate in, that you said really nicely, was we focus only on the tooth straightening side, which I call it the reactive side, right? Like we wait till things get really bad, then we're really good at reacting.
Duct taping. It's duct taping.
It's right. It's duct taping. What you said that was really interesting about that is that's all we have in a lot of cases, right? Like if you stop and think about it, if we're not orthodontists, meaning like our profession, broadly speaking, all we hang our hat on is that we're the best tooth straighteners. But when people start getting to these patients earlier, right, as you're doing, as I did, guess what? You don't have to be as good of a tooth straightener to fix the problem down the road. And that's something that you alluded to, is that you're not going to need the orth. So not only is this patient not in theory going to see you because, well, the general dentist or the pediatric dentist gained the trust and respect of the parent, which they should have if they went in younger and helped this child and helped their airway and helped coordinate them with whether it's myofunctional therapy or getting them to allergy or ENT and all the things you and I deal with every day that we know about, that a lot of our colleagues are still resistant to even discussing. So not only have we gained the parents' trust and the parents saying, oh my gosh, like you know, being the pediatric dentist and the general dentist, they look at them and say, you figured my kid out, you helped my kid. So their chances are they're not going to like go leave them and go to the orthodontist at 12 years old or 13 for a second phase if it's needed. And that's what I often say. But what you just said that I love is there's actually going to be no need, because the average pediatric dentist and general dentist can now just straighten the teeth out or do whatever easy treatment. I mean, the easiest thing it's minor movement. It's you've corrected the structural. You're not dealing with these, 13-year-olds that come in with deficient maxillary width, caved in lower arches, 2-3 millimeter anterior open bite, tongue thrust, vertical growers, steep mandibular plane angle, large adenoids, mouth breathing. If you walk into an orthodontic residency, you get tired trying to count all the patients that look just like what I described.
Absolutely.
And walk into the average orthodontic residency and walk into your practice, when I had my practice, and look at the average patient that walks in at 12 that we did a phase 1 on, and you'll see none of that, because we know that when you go in and address the structural, the foundation, the etiology, if there is an environmental cause, airway cause, et cetera, when you address, and to be clear, again, as the orthodontist, we're treating the malocclusion. We're not treating airway. We're not telling them diagnosing them with an airway condition. We're recognizing the signs and symptoms, that there's aberrant growth, which is our job. We're performing evidence-based treatment. You can have a debate if we're doing it younger than you think you're comfortable with, but we are still in the guidelines of the AAO and the AAPD, American Association of Orthodontics, American Association of Pediatric Dentistry. They both say, people say the AAO says 7. No, they don't. They say you should go see an orthodontist at the age at which the problem is detected, and that no later than 7. Exactly. No later than 7. AAPD says at the age at which these growth disturbances are detected, any age, like you said, could be in the first couple of years of life, you should be evaluating and performing treatment. And they actually include airway in that discussion. I learned that from Audrey Yoon, and when I had her on a little while ago, that they actually in the AAPD guidelines recommend that. So these people that say that there's no one saying you should do this, that's a lie. They actually, our 2 biggest organizations openly say this. The ADA is very clear about this. They put no age restrictions on this. They say at any age that you detect these issues, you need to find it, you need to work with your medical colleagues and perform evidence-based treatment to address it. And the other thing that's interesting when you were talking, and I don't say this part enough, I don't think, we argue that you have no place going in on a younger kid. People hear you say 3, 4 years old and just, they're just beside themselves. We do it on cleft craniofacial patients in the first year of life. So if you say we can't have an influence on the growth and development of the craniofacial complex, or as Kevin Boyd says, a craniofacial respiratory complex at an early age, why have we been doing it on cleft craniofacial patients? Why do we have NAM? Why are we molding, and why are we giving these obturators, and why are we doing all of this stuff young? Because we know we can reshape their growth very easily. Absolutely. And if we don't do it, then look at the cleft patient that walks in or the patient with a cleft that walks in the first time at 7 years old and has had no treatment prior, versus the one who you started on at 6 months of age and you were going through the appropriate processes of cleft craniofacial care. Look at that kid at 7. It's a different human. And so it doesn't take a big leap to extrapolate that to the patient who just doesn't have a diagnosis of a cleft, right? But is still growing with the same types of deficiencies, right? In terms of the actual maybe size of the maxilla or lack of growth or lack of coordination of arches or whatever it might be. So a lot of what these arguments we make are based on fallacy, and they're very hypocritical, because the same person who's saying you're out of line for doing what you're doing will have no problem with treating a patient with a cleft at 2 or 6 months or whatever the case might be, right?
So the intercanine width changes the same amount between H0 to H2 as from H2 to 20 years old.
Mm.
But if you have the intercanine area that didn't grow by H2, it's not going to grow.
Right.
Can't catch up in growth. So, why would you not want to correct it in a younger age? I don't even want to talk to people that try to fight it and argue and wait for the 6-year-old molars to erupt so they can put the iatrogenic bands on the 6-year molars and push those periodontally mature 6-year-old molars outside the bone at age 7.
Which you see all the time.
Primary molars are so much. Look at the divergence of the roots in the primary molars from age 4 to age 6. They are the best anchors that your mouth has. Use them.
Yep.
Don't abuse the permanent teeth with the orthopedic forces.
It's so true. And we ignore those side effects. And we just, again, the dogma, it's like, well, this is what we do. And we just kind of put blinders on and say, well, that's just what happens. We're so okay. I had a post recently and a reply to a blog online. And I said, like, why are we okay? Name another dental or medical profession. Clearly in medicine, it's not figured out, but they're trying. That isn't really, really trying to figure out ways to stop disease from happening, right? Every other profession is trying. We're trying to get people before they have type 2 diabetes, before they have heart disease that could lead to death. Like, we're trying to get at, we don't know the answers yet. We don't know exactly how to do it. But in dentistry, with sealants and preventative treatment, right? Routine prophylaxis, all things that evolved throughout the course of the profession with a preventative mindset. Fluoride and ingestion. So things to try. Again, you can debate whether you like these things or not. But my point is not what the modality is. My point is they're trying to have a preventative mindset, right? Just like you and I, we can debate the way you do it and the types. But the point is how do you philosophically, fundamentally disagree with being more proactive and trying to help these kids younger? And then we didn't even get into the medical literature with, Karen Bonnick's study and David Gozal and the Isaiah study from Nature Communications in 2021 with the just over 10,000 kids from the Adolescent Brain Cognitive Development Study saying that even gasping during sleeping alone leads to neurocognitive deficits and decreases in gray matter in the frontal lobe. I mean, this is medical data and information, and we literally, not only, as you said, don't go over it in our residencies, we get out and we act like it doesn't exist. I mean, Marianna, what percentage of orthodontists do you think know what I just said? That even gasping during sleep alone has been proven in the medical literature to cause neurocognitive deficits and changes in the amount of gray matter that lead to academic and behavioral problems. I mean, truthfully, what percentage of our colleagues do you think know that even exists as data?
I have no idea. I don't think not many.
Yeah. I think very small number. And it's to your point.
Just forget about the airway. I mean, this is the main reason why you have to be proactive in a young age. There is like no brainer. Now the medical community is starting to learn the need for that skeletal development in a younger age, because it's not the obesity that necessarily causing airway issues, but it's actually underdeveloped faces. And there is literature that is coming out, article after article, to suggest it. I cannot tell you how many patients I see with the skeletal deficiency that are very skinny and have sleep apnea. They stop breathing maybe 100 times an hour.
Yeah.
Our practice, and are fit and are going to the gym every day.
Yeah.
And they are fighting poor quality sleep every day. And just because the jaws didn't grow. Let's take the periodontal risks. So what about the literature and orthodontic treatment and periodontal risks? Well, all of the periodontal literature on the risks for recession, for dehiscences, fenestrations, has everything to do with thin phenotype, tissue phenotype, thin bone phenotype. There is literature in orthodontics before the era of CBCT, and there is the literature after we have CBCT. And there is very strong consistency that what happens as a result of orthodontic tooth movement, whether you use aligners or whether you use braces, the patient has less bone and less soft tissue supporting the teeth on average after any type of tooth movement, whether you do extraction therapy,
I was just going to say that.
Non-extraction therapy,
the
orthodontic treatment is a risk for the periodontal health. Right?
Yeah.
Not talking about the hygiene and all the gingivitis. We are talking just the amount of bone that is housing the tooth before and after we move the tooth. So,
and if anybody is out there doubting what Marianna just said, you probably don't have a cone beam. And if you do have a cone beam, you're probably not looking at the bone and the roots after you finish a case. Because I was very humbled where a case that looked beautiful before I had a cone beam. I had my ICAP Flex put in 2014. But I had no idea what you just said. If you've practiced long enough and treated enough cases, just look at your cone beams and look at what those roots look like and look at the bone architecture around those teeth before and after treatment. And I'm saying it could be a beautiful case. Extraction, non-extraction, doesn't matter. Look at them side by side. The thickness of the bone will be thinner pre and post in a lot of those teeth that you moved, even with great mechanics.
So there is not a single paper in orthodontics that shows that after we finish orthodontic treatment, the patient ends up having more bone than they started, unless you graft. So then comes the periodontist, because what orthodontic profession has done for the last 100 years, it basically fed the periodontal specialty. The majority of the patients that the periodontist sees that need soft tissue grafts, bone grafts, that actually crack their teeth because the malocclusion was never corrected. The patient, after straightening of their teeth, never got the canine guidance and anterior guidance and canine protected or group function. All of the interferences stayed on those posterior teeth. And now the periodontist has to take out cracked molar and place an implant. So the periodontists took the last 50 years and they said, we have to do something about it. have patients that are losing their teeth not because of the periodontal disease, but actually because of malocclusion and because they have no bone and no roots to support the teeth after to support the bites after orthodontic treatment. So they said, like, you have to do something prior to orthodontic treatment. We have to do those beautiful, invasive, aggressive bone grafts and the soft tissue grafts before you move the teeth, so you have less risks. Well, it may not be the answer to the problem because it's still considered a patching.
Yes.
So the tooth is designed to erupt in the center of the ridge, and the root development continues after the tooth erupts into the oral cavity. And the root is designed to be in the center of the bone. And guess what? We failed to identify and to study that part of growth and development when you have a primary dentition transitioning into the permanent dentition, what happens when it's normal and what happens when it is not normal. And I think today we have the tools to allow that tooth to erupt in the center of the ridge. Unfortunately, it should be happening naturally without any orthodontic intervention, but with all the environmental changes that we have created for our convenience, it's not going to happen. So now we have to do something about it. And the only time to do it in the primary dentition, you don't have to wait until the child has gingival recession at age 10 on those lower incisors. And now they need braces, and they can't have braces because the low incisors have no gum covering them. And because they have no gum, they have no bone underneath, and they need graft.
And we have an argument over the incisor mandibular plane angle within 5 degrees of where we should put it. And we totally ignore the fact that if we had done more proactively earlier, that tooth would have erupted into a normal biologic position in the bone with the tissue, and we wouldn't have to have that debate or the debate we have about expanding intercanine width. Look at all the literature and Little's incisor irregularity index. It's done after the canines have erupted into deficient bone, and you put them into periodontally unstable conditions. Where are the studies to prove? Because I've done it thousands of times. When you develop and grow that arch, when the primary teeth are there, the permanent canines erupt beautifully. And sometimes, and I have the CBCT scans to show it, literally a centimeter wider across from cusp tip to cusp tip than where those primary teeth, you expand a centimeter across the canines, and the permanent teeth erupt perfectly. And I can show you pictures of that patient 5 years down the road where with no treatment, those canines are still in the exact same position. So don't tell me literature and again the dogmas that you can't expand canines and extrapolate that adult treatment data to treating a young kid in the early in the primary or early mixed dentition and making that space at the time. So I feel like there's this conflating of the literature and the data and these absolutisms, right? Like you can't expand canines. Well, we're not talking about expanding your permanent canines. So one of the things you said that I think is really interesting, and a guy, general dentist, was on my show, Scott Province, a few episodes ago. And one thing he said, which I really liked, is, and I remember, I actually had him repeat it because I hope everyone hears this. He said, I wish every orthodontist could have to look at their cases 20 years down the road. And it sounds like in hearing you speak that because of your background in perio, that you've seen those cases 20 years down the road, because people out there might not realize, if they're not in our profession, that the average orthodontist has no clue what that patient looks like even 2 years later. And so would you agree that part of our curriculum, part of what we need to do better at as a profession, and maybe that would help us realize some of the harm we're actually causing, not maliciously, not directly, but by negligence in a sense, right? Not focusing on what we should be, just being reactive. And I'm not even talking about indicting us for our sort of sins of the past, right? We are where we are. We've done what we've done. My frustration is we should know better going forward. So do you feel like if orthodontists could get some more education in what these patients look like down the road, that would be helpful for them to realize some of what's going on?
Absolutely. I started a recall program where I try to bring patients 5-6 years after orthodontic treatment back to see where they are.
Yeah.
And it's amazing what you can see in cases that have been properly expanded and have been underexpanded, how they look, if they wear retainers or they don't wear retainers.
Mm-hmm.
So it's very important to look at your results many years going forward. So going back to what the question is, so what can we do?
Yeah, that's yeah.
The literature shows that early treatment is not effective. Well, what kind of early treatment are we talking about?
Thank you.
Putting brackets on the 2x2x6? That's not early treatment.
No.
That's patching.
Yep.
What about expansion with using removable expanders or
a lip bumper to expand or to maintain
Hyrex or
hypo headgear? Yep.
That's not early treatment. That doesn't address the structure.
Yep.
We have evidence today that you need to understand exactly what is happening to the face. So the face is not, the jaw structures are not growing wide enough at the level of the teeth, the level of the flow of the nose. And they are, I'm talking about at the level of the teeth, I mean the mandible, because the narrower the upper jaw, the wider the mandible is going to get at the base.
Yep.
We have evidence that the way the upper jaw grows is going to affect the shape of the mandible. So both jaws do not grow wide enough globally, pandemically. Both jaw structures are growing too short. So that's why we have crowding. We don't have room for the wisdom teeth. And if you are an orthodontist, I guarantee you have patients that don't have room for the canines, don't have room for the second molars, right?
Yep.
So because the jaw structures are not too far back, but actually too short. And they don't teach this in residence.
They do not.
And to compensate, because when the nose is not growing, you don't breathe through the nose, you breathe through the mouth, the jaws overgrow in the vertical plane.
Yep.
So the faces are getting longer.
Which is not debatable.
Debatable. So we are not growing wide and we are not growing forward enough, and we are growing too far down. And guess what? If we identify this path of growth in a very young age in the primary dentition, and we also identify the reason why it happens and do something about it, and what we have the technology to do today, and that's what we are doing in our practice, is we have the technology to grow jaws wider. We have the technologies to grow jaws longer. And the president say, what do you mean? She's crazy. We have that technology to grow jaws longer, not forward, grow them longer so we can fit more teeth in the mouth. And
what would be a way for those who don't know that you could, what would be a way to do that?
I don't leave it as an open question.
Okay.
I don't leave them, let them think about it and try to research. There is an answer for that. And we have the technology to control the vertical from the primary dentition to prevent those teeth from over-erupting. What does it mean if the tooth over-erupts? That means that alveolar bone supporting the tooth is going to be very thin. The gingiva, luckily, if the patient has thicker soft tissue phenotype, will be thicker, protecting it. But if the patient has thin gingiva and thin bone, and then you put these teeth in occlusion, that occlusion is not going to be stable because it doesn't have good solid bones, basal bone supporting it. So we have the technology to control the vertical overgrowth. You cannot control it unless you do intrusion once the teeth already over-erupted.
Right. I'm thinking of a, literally as you're talking, I'm thinking of a chin cup, you know, and I'm thinking, oh my God, is there anything more reactive and not looking to what's actually causing something than a chin cup? I mean, like, you're literally trying to stop this patient from growing vertically with zero effort to figure out why they're growing vertically and just chalking it up to this is the way they are. When
pushing the tongue back into the throat. So,
right. It's like, oh my goodness. Like, I mean, when you stop, when you really stop and think about it.
Vertical control in orthodontics, we are talking about intrusion of the teeth, but intrusion of the teeth means that we already missed the window. We allowed the teeth to overlap.
Mm-hmm.
We missed the potential of the growth of the jaws to express itself in the right plane of space.
Mm.
You cannot do it in the permanent dentition. You cannot achieve it in the late mixed dentition.
Mm-hmm.
You have to do it younger. And we are not here to discuss the tools. I want everyone to be curious and start researching and asking the question why. But we are in the most incredible time in our profession where we take it and fly, or we jump off the cliff and we let it sink.
Yeah. And one other thing I hear from people is how do parents accept this? So someone who runs a practice who's treating a lot of these younger kids, how do you explain it to the parents? You said 99% are coming to you with some sort of airway concept in mind, or in other words, are understanding the kid's not growing well, imagining physicians are referring directly to you, because that happened with me all the time once I got known for being someone who understood this stuff. What is that a challenge? Is it getting easier as you start to have a reputation as someone who understands this? Do you have some convincing to do as, hey, mom, I get that when you were a kid, we talked about treating kids at, 13, right? We waited until all their adult teeth were in. Everybody hears when people come in like, wait, I thought we had to wait until all their adult teeth came in, to now saying we're not going to wait till any adult teeth come in. How did you kind of parse that out in practice, delivering that service every day?
So we have a very nice library of documented cases from primary to permanent dentition when something was done, and then the same cases when it wasn't done correctly, wasn't done at all, and the child came too late. So luckily today, it's really not difficult to educate the parent, but we use a lot of visual x-rays and clinical pictures to educate them what happens if you wait and what happens if you are more proactive.
What if someone doesn't have that yet? Because I find a lot of docs I talk to don't know where to start. They believe what you and I are saying, but they've, number one, never been trained in how to treat these younger kids. They just don't even, the thought of treating a 4-year-old is just beyond them. And then two, they don't have any cases yet to show the parents that they know what they're doing. So how do you advise people who, because I know you teach a lot on this, how do you advise them to kind of jump over those hurdles?
Yeah, we go over this in our course on the early pediatric expansion, but I think if you don't have the cases, you can definitely start with the literature. Discuss with them the literature. Very early on in my practice, I developed a brochure together with the sleep physician where we talk about the literature and all the risks of jaw deficiencies and how they impact the airway, for example.
Love it.
Same with the periodontal literature. There is literature there. You can identify that literature and you can incorporate it in your treatment planning session. And you have to educate local referring doctors. And once they are educated and they advise the families to come to you for evaluation, I think
that's a big one. Yeah, that's a great point.
Word, it's going to be much easier for the patient to be convinced and agree with what you're saying. The problem that we have with doing it in a younger age is the problem that we artificially created, because doing orthodontic, orthopedic treatment in a young age should never be identified as early treatment, because in the mind of the patient, early means that they maybe can wait and reassess. Maybe being too aggressive and doing things too soon, and the child may outgrow the problem. So in order for you to really educate the parent correctly, you have to know the literature. You have to use the language based on the evidence. I'm not doing something myself that is not evidence-based. There is literature on that. And the early treatment that we call in orthodontics is already too late, because the early treatment, according to the literature, is after age 8, between age 8 and 9. That's not early treatment.
No.
So we created we are misinforming the patients, the public, based on using poor terminology. If I am going to talk to the parents, I'm not going to say that I recommend early treatment for their child. I recommend preventative treatment.
Preventative.
If they don't have any problems. But if I see the crowding, I don't treat sleep apnea. I don't treat upper airway resistance, but I am a specialist in the jaw. I know what the jaw should look in the primary dentition. I know what is the jaw should be looking in the permanent, in the mixed dentition. So I'm specialist in the jaw. Just like endocrinologist is prescribing growth hormone, I don't use the growth hormone. I can grow the jaw with orthopedic appliances. So my specialty is the jaw, is not sleep apnea, is not airway. I hope it does help airway. I definitely see and know that it will help healthy eruption of the permanent teeth. But I can take a 1-year-old, I can take a 2-year-old, and I know how to look for the jaw deficiency. And if you know how to look for it, you have to be able to, in a matter of 5 minutes. I don't think you need more to educate somebody that doesn't have any dental education, what is small jaw and what it should be. And if the jaw is too small, there are risks to the health, the risks to oral and systemic health. And I discuss it with the family, and I say you can totally wait, because we have been doing this by waiting for 100 years in orthodontics, and then we see complications. And guess what? What about the parents? If you really truly believe that it is a genetic problem, there is another problem that will be running in the families called habitational. If you live and are raised in the same environment with the parents, you will have similar problems just because of the similar environment that you live in, right? If you talk about periodontal risks, ask the parents, do they have any history of periodontal disease? Do they have any history of orthodontic treatment, gum grafts, dental implants, occlusal trauma, sleep apnea? Just ask the parents. And if they have family history, the literature is very clear. You have family history here. That especially increases the risks for that child to have similar pathology as they grow up. So you want to do something earlier, right? I want for my children.
How has this changed you in terms of someone who came out much like myself, who went to a profession where we help change lives, and we change them by giving people really straight teeth and really nice smiles, to now someone who still does that, but also has this other part where they change lives by truly changing the health and well-being of a young patient? What's the impact been on you of that?
Well, it was very difficult in the very beginning, because when I was starting my practice, I truly believed in the health benefits of what I was doing out of my residency. And I had a very difficult time convincing the patients that came to me just to have the teeth straight. They come with crowding, the upper teeth have spacing, the lower teeth have crowding. So how do you explain to the patient that just wants straight bottom teeth that actually the upper jaw needs to be even wider, needs to be more spacing, so we can close the existing spacing? It doesn't make sense. How do you explain to mom that brings the child with 2 rows of bottom teeth where the primary teeth are not exfoliating and the primary incisors growing in the second row, teaching them, oh, your child actually has a problem in the upper jaw, and it's expressed in the low incisor crowding, but the problem is not the low incisor crowding.
That's the symptom.
So you have to educate them. So 10 years ago, you have to spend hours to teach them that, and they could not believe that the problem is in the lower jaw. Now you have to do something in the top. Doesn't make sense. The problem is different. You expand them, and they question if you expand them enough. Oh, my child needs more expansion. Oh, I need more expansion. No, the child doesn't need more expansion. The problem is a multifactorial. We didn't fix everything. We can fix every problem of your body with expansion, right? So it's kind of now on the opposite side, but I have to say that 1% of patients comes to us with aesthetic concern. and 99% come with health concerns. They know that the crowding is bad for them.
Yep.
And they have some kind of airway issues. Like Audrey Yoon was talking about screening the patients. We have been screening every patient for airways since 2012.
Wow.
Since 2012.
It's amazing.
And once you answer all these 30 questions of the PSQ for kids, I mean, it opens so many doors for discussion, not only for that particular child, but maybe there is another family member that actually has all these symptoms and nobody has identified the problem until now. We are connecting the dots by connecting the facial maldevelopment to the airway symptoms that the child has. Or another family, or like how many times the parent would fill out the form for the child, say, "Oh, I should have my husband do it."
all the time. So or the brother. Oh my gosh, now that I think about it, her brother, this is her or she might say, she's a little of this, but whoa, her brother is like really bad. And all the time that would happen.
You can actually have the compounding positive impact on people's life.
Yes.
I remember last time I remember the patient came to us for cosmetic reasons. It was a second opinion patient. The adult male was very narrow, deficient maxilla, and he was in braces for 8 years.
Oh, jeez.
3 rounds of braces, and he had aligners, braces, aligners. Now he's in braces again, so he was not happy with his progress. Wanted a second opinion. So here is this orthodontist treating this gentleman in his 50s to straighten his teeth, and he can't close the gaps. And the gentleman is very upset that the gaps between the teeth can't be closed, but they can't close them because the tongue is pushing the teeth apart because the patient has severe sleep apnea. So he told me that he cannot sleep in the bed. He has to sleep in the chair because he chokes when he lays down. So I looked at his airway, and I don't remember right now if he had a sleep study by that appointment or not, but I told him that you need to treat the airway, you need to treat the jaw. And also weight was an issue for him. So anyway, he wasn't my patient, but he came for straight teeth, but I was able to connect the dots for him, explain to him that the spaces cannot be closed unless you address your airway, and you can't address the airway without addressing the jaw because the jaw is too small, the tongue doesn't fit in the mouth. It's simple.
It's not complicated.
He connected this. So he came back to me, and he disappeared because he just walked in for second opinion. So then he came back 2 years later, half of him. He lost a lot of weight.
Okay.
And he said, he just walked by. He lives in the area. He stopped by. He said, "You changed my life." It was a wake up. That consult was a wake up call. I don't know exactly what he ended up doing with his teeth, but he said, he may have had to get a CPAP because he didn't, I don't know if he did a jaw surgery. But he said it was a wake-up call for me. And now nobody ever before put together sleep and his bite and spacing between his teeth and small jaw, and it all came together and he did something about it. So what I'm saying is today, people don't come to us to get straight teeth. We tell them that when we are done, straight teeth is the byproduct of our gold treatment. Our gold treatment to address the jaws, to make sure the teeth fit properly, the teeth stay in the bone, that we have sufficient tongue space, that if we can open up the airway with that jaw treatment, we will do it. If possible, without surgery, we do it with SmartPay without surgery, if possible. If not possible without surgery, we will talk about surgery.
Sure. Yep.
And the teeth will look straight, but this is not the goal. When the teeth are straight and they function right and the patient can breathe, that's the goal.
Yeah, that's so well said. And I'd say to the residents all the time, we're so much better than just being tooth straighteners. Why do we relegate ourselves to just being tooth straighteners? We're so much smarter. We're so much better trained. We have such better education. Why do we just go through all this work, training, time, and energy just to be satisfied trying to straighten teeth better than the next guy or gal down the road. I'm like, I don't know. I mean, so few people, there's so many impressive people go into this profession. I mean, I am constantly blown away by the quality and intelligence and ability of our colleagues. I'm doing this now on a bigger stage and talking to people all around the world. It's mind blowing how talented these people are. And then so many are just okay with just focusing on trying to straighten the teeth or get that class 1 bite and not looking like you just did in that great example. Just why are we here? Why are we here? And then educating the patient and trying to do the best that you can with it. And I think that's a great example. Before we wrap up, I want to just ask you, some people know you from reading your name in James Nestor's book, Breath. How did that happen? I've never asked you about that. How did that happen, and how did you get connected with him, and what does it feel like to kind of be named in this now best-selling book that most people have read, heard about? I mean, I've read it. It's a great book. So yeah, how did that all come to be?
It's just a destiny.
Yeah.
So James, I didn't know anything about him. In 2018, he emailed me and he said, I wrote this book, Deep Dive. That was his book that he wrote before Brad. And I'm very interested in your research at Penn on the skulls. I want to know more about what you're doing. So somebody else recommended him to contact me, and I want to visit you. And I said, sure, come visit. So he came to visit my practice. He had a lot of questions about expansion, jaw development, malocclusion. So I kind of showed him some of the new things that we have been doing in 2018 for children and adults. And he really wanted to go to the museum. And I took him to the museum so he can see the skulls.
Yeah, wow, yeah.
He was fascinated by some of the 3D images of the skulls and the patients with deficient maxilla. He couldn't believe that they are so different. He came for a day. He spent a day with me, and then he disappeared. And then COVID was which year?
2020.
2020. So 2 years later, during closure, I think it was the end of April, I got an email from him. He said the book is coming out next month. So in May. And he sent me a beautiful copy, and now somebody stole it with his signature. I don't know. No, we gave it to some of our friends to read or family members, so I don't know who has it. But he sent me the copy with his signature, and the rest is history.
Oh, that's neat. That's really neat. Yeah, great.
I forgot about him because so many people contact us, like different magazines and different books or documentaries, and they want to learn more about airway and what orthodontists can do about it. So there are a lot of people that are working on different projects that are contacting, but then they disappear. Some of these projects are never getting finished. And he finished his book, and the rest is the history.
That must have been pretty neat, because it was more than just mentioning your name. I mean, he really, it shows. I mean, I would have thought.
I think this is the best book on breathing that you can read and learn as not being in the medical field.
Yeah.
Just for anyone that wants to understand the breathing, that's the best book.
Yeah. And it's interesting, because a lot of the people who we were talking about who really don't believe in a lot of this, and they're the naysayers, they are very critical of his book. And I've heard people say, oh, he's not a doctor. He's, he doesn't have the credentials. He's a journalist. And I said, that's part of the beauty of it, because he's not biased. He is a patient who is suffering himself, and he can look at it objectively. He hasn't been indoctrinated with these years of education. And as we started this conversation, kind of coming full circle here, talking about in the beginning, we were talking about the residency and basically making us so myopic and closed-minded on these things and dogmatic. He doesn't have those biases. So he was able to go talk to all these people around the world and just pull things from different people and just report them. And it was really neat to read it. And it must have been kind of cool to see your name there. And I said, I would have guessed he would have been there more than a day, because he really spoke quite a bit about, I mean, talk about what he observed and retained in that short period of time.
I was surprised how much he was able to retain. And somehow the whole department of ENT and sleep surgery at Penn read the book and invited him to give them a lecture for an hour because they were fascinated as sleep and airway physicians how well it was written and presented to the public. So I think he did an incredible gift to the medical and dental profession, putting all the pieces, puzzle pieces together. So I think, and I cannot tell you how many patients this book helped.
Yeah,
Soon
agreed.
as the book came out, about a month later, we started to get emails and phone calls from all over the world, people that have been suffering without understanding the reason, connecting the jaw to the breathing. And now everything kind of came together for these people. And they were contacting us to ask who is the provider in their country or in their state. I had this gentleman from North Carolina contacting me for the virtual consultation because before COVID, I did not offer virtual consultation. Today, we offer virtual consultation. So we have people contacting us from all over the world. And we are open to help them with advice because there are a lot of people that need our help. Not necessarily that they come to us for treatment, but I am open to talk to them if I can help them or guide them to find a provider in their country.
That's awesome.
So there was this gentleman from North Carolina that was really suffering from upper airway resistance, and he contacted me to ask me if he's a candidate for expansion. And now it's all happening at the same time as we are developing MARPI and able to expand adult patients without jaw surgery, without breaking the jaw. All happening at the same time. It's amazing history when we look back 50 years from now and see what happened over the last even 10 years. So anyway, so this gentleman said, I read the book. I was told that I need a septoplasty for 10 years and I was declining it and I was suffering and I couldn't really breathe through my nose during the day, during the night. And I read the book and I scheduled my septoplasty and I am just like a new person. From reading the book, I don't even need to talk to the doctor. He was already diagnosed with the problem. He was hesitating to go through the treatment. And now he wants to even get to a better situation. Maybe he can expand. But it's just amazing history, how much James has done for the public.
I agree. It's tremendous. It's raising that awareness. And honestly, you deserve a lot of credit for that too. I want to recognize you, that acknowledge you for that, because you're humble about it. This is just what you do. You're a warrior. You put your head down. But I don't think people realize how hard what you do is, fighting the establishment and the arrows you take, and the fact that you face them. You come at it with respect and dignity, but you're strong. You're courageous. We owe you a debt of gratitude as a profession, because as I was coming up through this, I was doing a lot of this in my private practice. And as I started coming up, I receive a lot of that feedback as well. And your name kept coming up. There's certain names that people were just like, Marianna she's really inspired me. She's really helped me. She's helped me to think differently about it. So just like you were saying with James, you've done that for people who maybe unfortunately wouldn't listen to someone like James, who did an amazing job, but doesn't have those letters after his name. Because there are people who just will be closed-minded to that. And they can see someone like you and say, well, maybe this is possible. And there's so many colleagues that I hope just hear your words and expand the reality a little bit. Put those dogmas aside, listen to what Marianna was saying. You're brilliant. You're respected around the world. You back it up with evidence and literature and data. And I really appreciate you coming on, sharing your wisdom, your knowledge, your time to do that. Honestly, don't hesitate in the future. If you need me, if I can help you in any way with anything you're going through or doing, you just reach out. And I know we might be I think we're both lecturing at the Winds of Change together, right? We're going to be the two orthodontists on the list to be on the schedule to lecture. So I'll be looking forward to sharing the stage with you then. But I really just can't thank you enough for all you do for our profession and all you've done.
Thank you so much. Thank you. Thank you for having me today.
Oh, you're very welcome. Great talking with you. And yeah, we'll talk soon.
Thank you.
All right, Marianna, take care. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening. And always remember, you have been blessed with the ability to do amazing things.